You guys doing?
How's it going?
Good, good. Finally got on.
I know I get confused when I go on technology. This live stuff is a whole nother ball game.
Yeah, absolutely. How's everyone doing out there?
All right, guys. So I just want to introduce you guys real quick. This is Dr. Nima Mehran. He's an orthopedic surgeon here in Los Angeles, California. He's going to be hopping on IG Live today, answering all of your questions on meniscal injuries. Last week, we pulled a lot of people. We got a ton of engagement, ton of comments. I would say probably 200 or so questions. What we're going to do, we'll start with some general topics, a general overview of what the meniscus is, some of the what meniscectomies are, meniscal repairs. If you guys have questions that come in live, we will prioritize those. So if you guys ever have questions, as long as it's related to the topic of the meniscus, we will answer those. And then if there's no questions, then we'll start answering a lot of the ones that we got last week. So I guess without further ado, do you want to introduce yourself real quick?
Yeah, good afternoon, everyone. As Mike introduced me, I'm Dr. Nima Mehran. I work out here in LA. Excited to be here. This is my first time, so take it easy on me.
This is basically our third or fourth doing this, so. Yeah, anyways, I guess we'll start with a general question. What is the meniscus and why do we have one? What's its role in the knee?
Okay, so great question, Mike. It's actually probably the most important question, right? So I brought a little knee model. This is my knee right here. The meniscus are these two little shock absorbers that go right in between the thigh bone and the shin bone. And the meniscus is made up of about 70% water, and then the rest of the 30% is organic matter and includes mostly collagen. So what the meniscus does is it bears a lot of the load of the joint. It absorbs the shock and it spreads the contact pressure so to transmit the load better, to prevent all that load from going into the shin bone. So when you're running, jumping, it takes a lot of the load and prevents you from damaging the cartilage on the edge of the shin bone.
Awesome. And then I guess this is a very, very common question that we get. And of course, there's a lot of different things that'll influence decision making, of course. But do all meniscus tears need surgery? That's a really common question that we get from people. Do I need to get surgery for my meniscus tear? Go ahead and take that away.
Yeah, I'm actually really glad you asked that. This comes up in every one of my clinics, I would say at least a dozen times. So the answer is no. Not all meniscus tears need surgery. And this is coming up more often than not because our technology is so advanced now that MRIs are picking up all these meniscus tears. And so patients are being told by a radiologist or their primary care physician, hey, you have a meniscus tear, see the surgeon. Well, the truth is without having mechanical obstructions such as locking, true locking, meaning that you cannot straighten or bend your knee because your knee is actually stuck or catching, without those kind of mechanical symptoms, you don't necessarily need a partial meniscectomy or a meniscus repair, the surgery for a meniscus. The reason is because a lot of the pain can just be coming from inflammation. So if you try things like anti-inflammatories, ice, and work with a physical therapist to strengthen the muscles around the knee, a lot of times you can actually avoid any type of surgery.
I think that's a really good point, and it brings up not just meniscus injuries, but just a lot of injuries in general. It's not necessarily the injury itself, the lesion itself, the quote-unquote damage itself that we may see on imaging studies. It's the inflammation that we're feeling and that our brain's feeling that causes pain. So it's important to know that just because you're in discomfort and or you see something on imaging doesn't necessarily mean that it always has to be repaired. So that's a really good point. I want to kind of
it's a great point, Mike.
encourage on. Okay, so going off that, when they do need to be repaired, what is the difference between what a meniscectomy is and then what a meniscal repair are? Because those are the two most common meniscal surgeries. Is that correct?
So yeah, most commonly we're doing partial meniscectomies. Total meniscectomies, which is removing the entire meniscus, that we don't do that too often anymore nowadays. It did happen historically 30, 40, 50 years ago. But we have now realized that the meniscus plays such an important role in our knee joint in terms of the shock absorption and the joint mechanics, that our goal is to take as little meniscus as possible. So a partial meniscectomy is when there's a tear and that tear is either causing a mechanical obstruction or has failed conservative therapy with anti-inflammatories and physical therapy and injection. So now we decide, hey, we're going to go in and we're going to remove that part of the tear and remove as little as possible, because the more we remove, the less that joint is supported, and the more contact stress and pressure is going to be able to go into the shin bone, the tibia, from the femur. So we want to remove, again, as little as possible the partial meniscectomy.
Awesome. That's really, really awesome. And I think that's a big key is that now, I guess, let's talk about, so that was more the partial meniscectomy. When people need to get meniscal repairs, can you go ahead and explain what a repair is? And I guess your thought process on when someone needs a repair versus when they just need a little bit of shaving as an partial meniscectomy.
Absolutely. So my goal as a surgeon is every time I go into someone's knees, I want to save as much meniscus as possible, and if possible, repair it. That should be my number one goal, so I can provide them with their normal anatomy and protect the joint as much as possible. Now, the patients that generally need a meniscus repair are those that have a tear that's usually, I don't know if you guys can see here, on the outer 1/3 of the C. There are two menisci, right? There's one medial and one lateral. On the outer third, the menisci have good blood flow. So if the tear is in that region, we can generally repair it and it'll heal because of the good blood flow. In the inner 2/3, the blood flow is not necessarily as good. So the indications for meniscal repair for me are younger patients, generally under 40. If they have a tear in the outer third of the medial or lateral meniscus, if the tears are vertical, meaning the tears are going from the bottom of the meniscus, then we can put sutures in against the tear and they heal nicely. If the tears are radial, going directly perpendicular into the meniscus body, those don't heal as well if you try to repair them. So again, if they're in the red zone, which is the outer 1/3, the patients are under 40. If they're vertical tears, the patients have no mechanical alignment. Because, right, if we repair somebody who has a mechanical alignment and they're putting more pressure in that area we repair, it has a higher likelihood of failure, as well as if the tears are acute. Tears under 6 weeks generally do better. The studies have shown that it's hard to pick a certain timeline, but more acute tears, more recent tears respond better to repairs. And finally, if you do a repair with an ACL reconstruction, there's been shown to be a higher success rate of the repair and the repair takes, because again, what the problem with the meniscus is the blood flow. So when you repair the meniscus and you're doing a concomitant ACL reconstruction, the bleeding from the ACL reconstruction from drilling into someone's bone and the bone marrow and the stem cells help that meniscus truly repair.
That's awesome. It's so cool how amazing the body is at repairing itself. You know, like I think we think that our bodies are really fragile and they're not. Our bodies are capable of freaking amazing things. And I think it's just with the, like you mentioned in the beginning, with the advent of technology, we're starting to see more and more what's going in on a microscopic level, not just what we see out here. We're like, oh, there's damage. But there's been damage for centuries. We've always had it. We're just better at detecting it now.
I couldn't agree more. Absolutely.
All right. So we had a question early on. I'm going to scroll up a little bit. This is from Struon23. Can you damage your meniscus by hyperextension?
So yes, you can damage your meniscus in many forms. Hyperextension, loading and twisting, which is the most common form. But I've seen hyperextension injuries have meniscal tears.
Another quick question from the live. This is from Alejandro93. What about a posterior horn separation of the medial meniscus? I'm not sure what he was referring to, but
he may be referring to a separation. There's two things he could possibly be referring to. One, again, is if we look here, the posterior horn is the back, towards the back of the knee. Here's the anterior horn, here's the posterior horn. And so he could be referring to, one, the meniscus actually separating over here from the capsule around the knee. So we repair those because it has really good blood flow. Or he could be referring to where the meniscus actually goes into the bone at the root. The roots go right into the bone, and those actually have great healing rates because what we do is we put some sutures in it and we drill a hole and we pull it back down into the bone, so the stem cells in the bone marrow help that heal nicely back to the bone.
That's awesome. That's awesome. We got a question here from Joyce Replacement Therapist. What activities to avoid early post-op with repair to protect the repair?
Okay, so generally with the early post-op, different surgeons have different protocols. What I usually do is I allow the patients to bear weight with crutches. However, I do not let them range their knee past 90 degrees for the first 4 weeks. The reason is most commonly we're fixing posterior horn, so back here. So if the patient's going too far into flexion, they can be really digging into that repair and possibly breaking it up. So I limit them for the first 4 weeks in terms of range of motion. Then what I do is, and this is common with a lot of my colleagues, is the first 3 to 4 months, we don't let them squat past 60 degrees. So it's okay for them to get range of motion and work on that. But range of motion with weight bearing, like in terms of squatting, that really puts that repair at risk as they dig down deep and they're getting past 60 degrees and flexing and pushing their weight into that repair. It can cause it to open up. So we want to start getting some healing before we allow them to do those things.
100%. And then I guess let's go, we just talked about meniscal repairs right there and some of the weight bearing precautions that you mentioned, limiting weight bearing, certainly loading weight bearing past 60 degrees, which so you guys know, this is my knee, this is my thigh, and this is my shin bone. If I'm like this, kind of like in a squat sitting on a chair, that's 90 degrees. So what Dr. Mehran is saying is we're going to limit it to about 60 weight bearing for the first 3 to 4 months to give time for that repair to heal. So that's on the meniscal repair side. But what about these partial meniscectomies that we talked about earlier? We're just shaving a little bit of that meniscus off. What do you recommend for weight-bearing precautions and range of motion for them?
Oh, good question. So generally for partial meniscectomies, we have no weight-bearing precautions and no range of motion restrictions. I allow my patients to bear weight as soon as they feel comfortable getting off crutches. I would say my average patient gets off crutches within 2 days. And they start working with a therapist immediately, even next day. They start working on their range of motion. And most of them come in for their first visit at 1 week and they have their full range of motion already. Mm-hmm. It's pretty impressive with a partial meniscectomy.
They're awesome. I just had a new one last week. Yeah, we get them in within 1 or 2 days. We're working quote unquote on range of motion, but like you said, most of them already have, for the most part, full range before I saw them, unless their range has been limited for years prior to that partial meniscectomy. The goal for me as a rehab specialist is in those early weeks is to limit swelling. That's going to be my biggest enemy per se. The range, like you said, is really there. I'm going to try to limit swelling as best I can, and just try to get that quad going and firing as soon as possible. So that's it looks like for me. But when people come in with meniscal repairs, like you said, there's a lot more precautions, a lot more things that rehab specialists we have to be more cautious with. Because we do have to respect that there's a lot more of a surgical insult, I guess you could say, to that meniscus, and we have to respect tissue healing timelines.
Absolutely. But to your point, Mike, I think you nailed it. Swelling is the most important thing, because if I think of my patients that are kind of a little bit slower to get going, what happens is they go back to work immediately because they don't miss work. They're standing all the time. They really swell up. And then, next thing you know, it's been a couple of weeks and they're a little bit behind because they're used to
going back to work. I think is the big one. You have to find ways. You can't just say you can't go back to work, but we have to find ways to limit the amount of load that they have on their knee. Know that whatever we're doing in rehab, it doesn't even come close to the amount of load that the person's going to have on the knee throughout their day-to-day activities for an entire 16, 18 hours that they're up. So if they have to go to work, find ways if they can sit down a little bit more. Find ways if you can just prop the knee up for 10 minutes with ice every hour, even if it's every 5 hours, that's better than no ice at
Absolutely.
all. You got to find ways to decrease that load. It doesn't matter what we do in the clinic on the rehab side, but if we're not changing our activities in those early phases, we're just going to be fighting swelling. It's going to be this back and forth battle, and most patients will get behind. So.
Yeah, and I think that most patients are genuinely just really great people, and they want to get back to work. They don't want to leave their friends or their colleagues, but they actually do themselves a disservice. And sometimes they end up taking off more time in the back end because of the front end when they should have just relaxed a little bit.
Yeah. I know a lot of those people that want to get back, I always recommend going with a single crutch, and most of them don't want a crutch. I go with the single cane. I'm like, just have it there. It's going to tell people not to bump into you. You can put a little bit of weight through there, but a little bit of weight over 10,000 steps a day is going to save you a lot of load on that. So we got a question here. This is from Happy Raindrop. If my patient is diagnosed with damage, do I make some provocation testing to find out which parts are damaged, or is it more harm? And what muscles should be prioritized in rehab? I guess I can go what I do on the rehab side, and then let me know what you think too.
Perfect.
But I know for our meniscal testing, yes, we can. We're good at causing discomfort in some areas, but they really don't tell us too much about where they are. Yes, the likelihoods of some of those tests can tell us location of them, but ultimately, as a rehab provider, it's not necessarily the anatomy that should dictate, what we're going to be doing in the clinic. It's what the response to your loads are and the response to your exercises are. So you don't necessarily need to, provoke them, but try to find ways to get that quad going. Try to find ways to get the hamstrings going. Try to find ways to get the glutes going. Try to minimize their load, not just in your rehab program, but overall what they're doing throughout the day. Because that throughout the day, walking and whatever they're doing outside of your clinic, like I said, it's going to be more than whatever you do in the hour that you have with your patient.
Mm-hmm. I totally agree with you. Now, in terms of the provocative testing and what I do in clinic, if I see a patient that I have that has a likelihood of a meniscal tear based on history, the thing I care about the most is their range of motion, because what I want to do is I want to compare it to the other leg that has no issues, and because there are a lot of patients who, for example, have 5-10 degrees of hyperextension. And so if you don't take that moment to really compare it to that normal leg, God gave us pretty much 2 of everything. It gives us a way to compare things, right? But if you don't compare it to that normal leg, you may think that somebody is getting all the way out to 0 on their injured leg, and that's great, they're in full extension. But really, if you didn't compare to that other leg, which hyperextends 10 degrees, you're not noticing that they actually have a locked knee and they can't get all the way out. And so I really, really care about motion first and most importantly. The meniscal testing, they're very specific and not always sensitive. But I have them do most commonly McMurray's and a Thestley's. And if they're positive, I'm getting the MRI anyway. And if they have joint line tenderness and a positive meniscal provocative sign, getting the MRI to confirm. And if they have a mechanical symptom, it's surgery. If they don't have a mechanical symptom, I'm therapy all the way, and with anti-inflammatories and plus or minus an injection.
Let's go back to that point. I think that's good. So even if you have a diagnosed meniscal tear through the MRI, that's true diagnosis, and in the clinical findings, joint line tenderness, Thestley's, McMurray's, a lot of our testing. Go through your kind of thought decision on what's the next steps for those people. And you already kind of hit on it a little bit about the range of motion and when going therapy or surgery, but can you talk a little bit more about when you go therapy and more or less why, and what are some of the reasons why?
Yeah. So the thing that I like to do the most is if I want to find out from them if they think subjectively they have any catching or locking. If they tell me yes, then I'm paying close attention. If they tell me no, they've never experienced it, already my answer is going to be generally go to therapy. Especially if they don't have like some type of meniscus tear that I can tell on the MRI could actually cause an obstruction, like a bucket handle.
Because catching and locking is for some of our listeners. Can you explain what that means if they're new to locking?
So a lot of times for the locking specifically is when there's a flap tear in the meniscus, and it could be something like this. Let's imagine there was a tear in this meniscus, and I can't really create a tear here, but if I flip it over as if there was a tear, and now it's almost like a bucket handle. And then what will happen is the knee cannot straighten all the way because the meniscus is caught. And so that's true locking. And if that happens, you need to do something because that can affect their range of motion. The meniscus may be able to be repaired, and you want to be able to repair it instead of having them continue to ambulate on it, might walk on it or play sports and then tear it up more. And then now you have to take it out instead of repair it. So that's locking. Catching is a sensation that patients describe more. They'll say that they feel like a click, and then they feel like something's in the way for a second, but it doesn't ever truly lock. And that's kind of their description. But if they describe those things, I am now making sure that surgery is not the right decision. But if they don't describe those things at all, my answer is always I want them to start with therapy, and I want surgery to be the last option. So I would want them to go to see a therapist because a lot of times after an injury, what happens is the knee is inflamed. So the pain's coming from the inflammation. And on top of that, now the quad has been inhibited. The quad is super weak. So what they say is that their knee's giving out. But their knee's not giving out because of the meniscus injury. Their knee's giving out because their quad is weak and they can't completely hold a straight leg. So their knee kind of gives out and bends a little bit as they're walking upstairs or something. And they think, oh my God, this is something I need surgery for. When really, if they see you, Mike, you and the prehab guys, you spend a few months with you, that problem's solved. Their inflammation goes down and they don't need me. And that's ideal for everyone.
Love it. Love it. Hopefully that answered Gotham City, your question on operation versus conventional treatment. And again, I'll just kind of reiterate again, it's if they have those mechanical symptoms, those locking, that clicking, and we could potentially be doing more harm by having them continue to weight bear, continue to do their activities. And we're definitely thinking that surgical route. But if not that, let's try to be as conservative as we can. We know that if we can get that quad strong and we can decrease that inflammation, people are more often than not going to do really, really well and respond to conservative care. And then, of course, if that patient's still not able to achieve their goals, say we're 3-6 months down the line, that patient's still not able to run that marathon, they're still not able to do, the stairs with their husband or their wife, and they're still not able to do the things with their kids and get on the ground, then yes, let's start thinking about more operative procedures so we can get them to their function and be able to do the things that they want to be able to do.
Exactly. I always tell patients I want to be a meniscus saver, not a meniscus shaver,
Yeah. Hopefully that talk Tara too. You asked what are some of the major signs of someone with meniscal problems. Hopefully we were able to answer in that question. The second part of his question is how can you tell if it's not something else?
Well, so it's a tough question, but basically, we're looking for, it's a history and physical exam, right? So you listening to the patient, finding out, was there a normal presentation like a meniscus tear? Or do they have pain localized specifically to their joint line? Do they have those mechanical symptoms? Did they have like a twisting type injury? Those are the common things that happen. If not, and their pain is a little bit more, if their pain is a little bit more proximal, so closer to the head, or distal, closer to the foot, it could be something like an MCL. A lot of times people will have joint line pain, but they actually had a valgus motion and they tore their MCL from the top on the proximal side, and it's truly an MCL injury, and those go misdiagnosed as a meniscus tear until we get the MRI. So that can happen. And sometimes people actually have, especially with older people above the age of 50, they have something where they have a little bit more, their meniscus isn't as robust, and they kind of have a really bad confusion, a bone bruise. And that's doctors or therapists to be a meniscus tear. That's the other one.
That's interesting. This is the question that's coming to me. What are your thoughts on like fat pad irritation, and I guess conservative approaches or surgical approaches? I've heard from some people that they're now removing the fat pad. Is that my understanding? Is that true? Or
yeah, so there was a gentleman, an orthopedic surgeon, who he did a study, and what he did is he basically he scoped his own knee and found out that the fat pad had the most irritation, and it had the most nerve endings and caused the most pain. So people have fat pad irritation, impingement, and these things can happen. I like to treat that as a diagnosis of exclusion, meaning that's kind of the last option, right? Because I've seen 2 of those in the last 7 or 8 years. They're not super common. I've treated them both with surgery after failed conservative therapy for like a year or so, and then failed injections, anti-inflammatories, physical therapy, and then did surgery, and both of them improved a little bit, but it didn't go all the way. It wasn't like a perfect answer.
So when you see that on MRI or people come in with that, do you think it's more of a consequence of something else rather than the source, I guess you can say? I mean, yes, the pain could be coming there. There's a lot of nerve endings in there. But I guess, more of a sequelae of things, not just as the single thing causing discomfort, I guess you can say.
Yeah, absolutely. Generally, in my experience, and this is mostly anecdotal now because I'm speaking about my own experience and not research, I've rarely seen it be the actual fat pad, and it was generally something else: bone contusions, meniscus injuries, swelling after an ACL, things like that.
Okay, awesome. This question is from Shubham26. I want to say he's saying, I think I have a bucket handle tear on the lateral aspect of the meniscus that's not really nagging, but it definitely exists. What do you recommend?
So I'm a little bit more aggressive with that now. And the reason is because if someone has a bucket handle tear and they continue living their normal life and they play their normal sports or do their normal activities, what they can actually do is they can take the meniscus is truly a C. And if the bucket handle is going all the way across, they can actually amputate it. And now they're left with less meniscus when it could have actually been repaired. Bucket handle meniscus tears are generally the ones that we repair, and they do fairly well if you do a good job on your repair.
Yeah, so even if it's not nagging, just because of the physiology, the pathophysiology of a bucket handle tear, probably more leaning towards a repair.
Exactly. You don't want to amputate that and have 60-70% less meniscus when you could have saved your entire meniscus.
Yeah. This is a question from Vincent Byner-Voet. When is the amount of swelling okay, quote unquote? Every now and then I have a patient who still has trace of swelling after greater than 12 weeks post-op partial meniscectomy.
Okay, that's a very good question. So generally, there's a lot of patients that have, and I think he means more of an effusion, right, in the joint, the swelling in the joint.
That's what I'm thinking.
Yeah. And so generally, patients will have a little bit of a trace effusion for even months, especially if they're younger and they're getting right back to their physical activity and sporting and different sports. So it's okay. I've noticed it. I've noticed even some people having some very, very minimal trace swelling even up to a year. I always tell them at a year. In general, they'll see their maximal output.
Mm-hmm. This is something that's helpful too. What do you think the timeline for the little the little portals that you make on the meniscectomies? And you always get the little raised bumps. How often or how long do you expect those to? Patients are always asking, They're always asking. I don't really know.
Yeah, I think, that just depends on how we decide to do our sutures. Sometimes when we do the under the skin sutures, they look prettier, but what ends up happening with those are they can get a little bit of tissue and raise that bump. And the people who are doing more of the simple sutures, like the nylons, just directly over it and cutting them out, I don't see those bumps as often, but generally within 3 months they're gone.
You're gone. Okay. This is a question from Mo Atabi. What is the best, I want to say this is soft tissue techniques for initial rehab after meniscus surgery. I think that's what he's trying to say. I know for me, when I see people after meniscus, like Dr. Moran said, range of motion is the most important thing. So if there are certain structures that are limiting range of motion, those are things I'm going to target. The hamstrings are limiting the extension, let's go for that. If the quads are limiting flexion, let's go for that. Even on these meniscectomies, or even the repairs that aren't limited by range, I mob the crap out of the patella. Like that seems to be for me the most acute pain structure when people have acute pain. It's not necessarily maybe causing any inflammation or causing anything directly related to the surgery itself, but those are the things that people get discomfort. They start getting patellofemoral. I'm not going to call it patellofemoral pain syndrome, but if I mob that patella and I can keep it mobile, I can minimize a lot of the discomfort to get around the kneecap. So that's something I do. Okay, so this is from M. Scott 63. What point do you decide to fix the meniscus when we talked about this, when the MRI does confirm a tear? Treat the patient or treat the MRI? I guess we can reiterate, but.
Okay, yeah. So, how you doing, Scott? I think I responded to a few questions in the past, but so it goes back to it again. You always treat the patient. You never treat the MRI. 50% of there was a study done by the group out at Rush, and they showed that 50% of the players in the NBA have an asymptomatic meniscus tear. So they're completely asymptomatic. We don't want to take these guys to surgery and either shave their meniscus and give them less protection, or B, try to repair something and keep them out of play for a long time. The bottom line is, no matter what an image shows, if someone's asymptomatic, you just watch and wait.
Good question, M. Scott. All right, next one we have is from Green Body Codes. So it looks like this guy may be a gym owner. So a new member comes in saying bad knees. Doctor says I have bad knees. It's a meniscus, often years ago. Key exercises to build up and improve the knee. It's going to be quads. You got to get that quad strong. The quads are, your weight-bearing joint of the knee. It's one that's supporting yourself up. But it doesn't mean you only need to focus on quads. Focus on everything in the lower extremity. When I see treat people for rehab for lower extremities, your goal should always be to get people to single leg exercises. That's really where you're going to see asymmetries from side to side. And you're really going to work on people's control and their neuromuscular control. So work on everything in the leg, really focus on the quad. A lot of these people, I don't know if I've seen a single person with meniscal injuries that has a strong quad unless it's some acute injury. Almost everyone has a weak quad. So definitely have a quad. This is from JP. It says pain with deep open kinetic chain or closed kinetic chain knee flexion. MRI is clean. Meniscus special tests are negative. Mulligan tibial IR helps. Okay. You want to hit with that first? If not, then I can.
Yeah. So generally for me, as long as you don't have patellofemoral cartilage damage, open chain is great. So I always start with closed chain, then I go into open chain. The only patients that struggle with open chain and have a very good reason why are the patients who have damage under their patella. Because what happens is when you're doing open chain, there's been studies that show you have an increased patellofemoral contact pressure. So that's obviously going to bother someone who has a vulnerability, underneath their kneecap, and there's some cartilage damage.
Correct. I'll also add to that too. Is this you have to treat the patient in front of you. So just because the MRI is clean, the meniscus special tests are negative. If they're having pain with deep open kinetic chain or closed kinetic chain knee flexion, you got to build up their tolerance to those loads. Whether we know what tissues may be irritated or not. From the rehab side, I'm not going to always know that, and whether it influences the exercise I do is, it can, but know that you have to build up your tolerance to them. So say they're getting discomfort at 60 degrees of knee flexion. Well, let's start them at 40. Let's work on isometrics. Let's work on different rotational ranges, like work on torsional things that are quote unquote stressing structures that we may think may be implicated, but we're not reaching that pain threshold yet. And let's get the body, and more importantly, the brain, used to those loads, and then slowly we can build them up in a deeper and deeper knee flexion angles.
Yeah, Mike, I couldn't agree with you more. I think the problem is all of us, and I speak for myself. I think we live in this world now where we have the world in our palms with high tech and all these apps and telephone. It's awesome, but we all want satisfaction and results to happen immediately. And sometimes I think we don't recognize that it's just going to take a little bit of time. And, you know, if you spend that time with a therapist for 3 or 4 months, you know, you're going to get the results. You just got to slowly progress and not try to rush it.
Yep. Hard work pays off. You got to know, but you got to put in the hard work. Nothing's ever fast and immediate. This is maybe a more personal question. This is from Adam. I had a lateral tear, first surgery 1 year ago, trimmed some stuff off, still had pain. Second surgery, repaired it 4 months post-op. How likely for me to return to high-level soccer? Cheers.
Well, Adam, that's a really hard question to answer. You know, it's always hard to answer a question when you weren't the one that saw in the inside of someone's knee.
Yeah.
It really depends on, you know, how much of your meniscus is there, what they repaired. Did they repair the posterior horn? Did they repair the root? But generally speaking, if I do a meniscus repair, and the most common type of meniscus repair is in the posterior horns, or the back corner of the root, I would say usually most athletes are returning around 6 months.
It's a good timeline. So 6 months, guys, for most people on a very general, normal repair.
Well, one thing real quick, Mike, we have to remember timelines. You should never think that a timeline is absolute. When I say 6 months, it's general. You know, there are athletes, you know, even with ACLs that I take care of that aren't returning until 15 months because they're not mentally and physically ready. And then I have some returning at 9 months, you know? So you should talk to your therapist and your doctor, and they should talk to each other, and the three of you figure it out together.
Yeah, I'll just piggyback off that too. Yeah, timelines aren't everything. Timelines may guide what we know from a physiological basis when the tissues say they may have full blood flow, when they may be more like the constituents of the original, but that doesn't mean that all the rest of your body is ready, not just from the local structures, like how strong your quad is, how sensitive or desensitive your tendons are, and then what's the rest of your body look like, what's your core look like. It's like most important is return to sport athletes, it's physiological, you know, for psychological readiness. And that's the biggest thing I think we work for in the ring. Are they ready up here? Like, are they mentally prepared to go back? Are they still fearful of certain things? And that's really one of the biggest, I think the most rewarding and also the most challenging thing as a therapist is working with patients on the psychological component of it. Definitely if they hurt themselves playing that sport, getting them back to that level. As we see with a lot of these ACLs, the reason they might not return fully to sport is more from here, because if you look at their objective testing, it could be dead even. But it's this part that they don't really have.
Well, I couldn't agree more, man. I can't tell you the number of times I sit there and talk to patients about, do they feel ready in their head, you know? And, you know, there's a lot of evidence that talks about braces. Do I need a brace to go back? I get that question all the time. Yeah. And the evidence says you don't need a brace. But if you feel like you need a brace, use the brace. All I care about is you feeling more confident, because you're going to have more injury with confidence.
Oh, yeah. 100% agree. And that's where, too, like, this is more going off the clinical side, but not everything is always research. You know, that what you feel and what you care about really is really important, and it really matters. If it's going to give you the confidence to do that activity, 100% go with it. I don't care what someone else tells you. If you feel better with it, you're going to do it. So, all right. So this is for the Honjo 93. Can a medial meniscus separation of the posterior horn capsule heal on its own? There is no locking, just very minor swelling.
That's a really good question. Now, that area has the better blood flow, so it can heal on its own. I've noticed most commonly, and it's probably because we're going in to fix the ACL anyway, a lot of times the ACL and the meniscus are torn together, is that usually what happens is when the ACL tears, there's so much bleeding in the knee that if there's a small tear in the meniscocapsular junction of that posterior horn of either meniscus, they can actually heal beautifully because of the blood flow from the ACL. Now, alone, when there's no ACL tear, I've noticed more often than not, sometimes they still need a little bit of help. But I have seen some where you think there's a meniscus tear back there, and you go in and they have healed because there's better blood flow. It all comes down to blood flow. It's all about biology.
Yeah. And then just to recap for those of you that joined a little bit later, so early on we were talking about different areas in the meniscus, and it's that outer 1/3 that really has a lot more blood flow and ability to heal. So Dr. Mehran was saying that's part of his decision-making process when it comes to opting between a meniscectomy or a repair. So that's a small section of it, but a part of it. This is a question from Ray John, strategies to help with swelling. I think I talked about some of these. We talked about icing. I know the literature is kind of out there on icing. I still do it a ton, because even if it may not be helping with that inflammation, which we do know within the first couple of days, it's going to help with pain. We know icing helps with pain. And icing also gets you off your knee. I think the most important thing is looking at total load throughout the day. How much time are they spent weight bearing on that leg? It doesn't have to be quote unquote icing, still good. But as long as they're spending less time on that knee, they're going to have less weight bearing forces through it, and it's going to help with the swelling. Just have to look at total load. Anything else?
Yeah, so I agree with the icing 100%. There was a study that showed that icing actually, with total knees, it helped a lot with range of motion immediately. They had better range of motion, those that were icing. But I'm a big fan of icing because I do feel like it decreases swelling. I do think it helps with pain, and patients actually say that it does. The patients who do it all the time, they love it. More important, like that, is elevating. You got to elevate your knee above your heart. And you want to make sure it's above your heart because your heart's a drain. You got to get that fluid out. And the third thing that I recommend to people is, our feet are in a dependent position. Every time you stand, gravity takes that fluid from your knee when you have knee surgery, and it brings it down to your feet, and your feet and ankle are swollen. So one of the things you can do is you can get compression socks, and they really do help, especially if you're going to work fast. I have a patient who's a comedian, and he recently had surgery, and he's standing on his feet. And so I told him, get those compression socks. That's going to decrease that pressure alone and decrease that swelling. So that helps too.
Oh yeah, compression socks are huge. I think what we're saying, like just staying active too, like if you think of the muscle pump too, what our quads do, what our calf does, what our hamstring does, as we get a muscle pump, we're able to help also with some of that fluid and try to get it out as best we can. A lot of different strategies to help with swelling, but know that that's your number one goal. If you just had any surgery, swelling. You protect the surgery and then swelling. This is a question from Vincent Minor Voet. What are both of your thoughts on the failure rate of meniscal repair? Should it be repaired, or should someone just calm it down with offloading, like crutches to be safe?
So, it really depends where it is again. So the meniscus, depending on the tear pattern, can or cannot usually be repaired. Some tears are much more amenable to repair. If there's a tear in the again, with where the capsule meets the meniscus, or the outer 1/3, and there's good blood flow, and it's a longitudinal or vertical tear, so it's going, up and down, where the meniscus is a C, it's going up and down. Those repair and they heal very well. The repair success rates are above 80% in some studies. So those do excellent. But if it's a radial tear, so you have a C like this, and the tear is going this way, those don't heal that well because, one, they're usually in the white junction, and they're and their tissue isn't that robust, so they don't do very well. But yeah, so I would repair them if they're possibly repairable. If not, and they're not causing mechanical symptoms like we said previously,
I want to treat them now. Off that too. I think you bring up a great point for everyone that has maybe a meniscal injury, or you're having a meniscal surgery. You are different than every other person that has had it too. We just explained someone may have a tear, but that tear being different is going to completely change what operation may be done, what the entire rehab process may be. You know that you can't compare yourself to that person next door. If you have a friend that had meniscal repair and you're getting meniscal repair, it could be a completely different type of surgery, completely different type of rehab process. So don't compare yourself to others when it comes to your knee, and listen to your surgeon, listen to your PT, and listen to your body.
Yeah, and actually, one more comment. One of the most common things that happens in clinic when patients have had a meniscus surgery, they say all the time that they have they've had a meniscus repair, and every meniscus surgery is not a meniscus repair. And more often than not, we find when we get their operative note and stuff that they actually had a partial meniscectomy. You have to always remember you are your biggest advocate, and so have your op notes. Ask the surgeon clearly, would that have a partial meniscectomy or repair? Those are not the same surgery, and they can affect future issues and future surgeries.
Oh yeah, Know your body. Do your research too. There's so much out there, but also don't get inundated with it, and don't believe everything that you're reading online, because everyone's different.
Yeah.
This question is from Hudson. Wolver's thoughts on PRP injections to promote healing
for meniscus tears. Okay, so PRP injections currently, the research has shown they're really actually indicated for two reasons. One is tennis elbow. There are several randomized controlled trials that have shown that it's been helpful in tennis elbow. So that's lateral epicondylitis. The second one is in mild to moderate arthritis. There's been several randomized controlled trials that show that compared to a placebo, for example, it's been very helpful in mild to moderate arthritis. Now, I've seen it work in certain areas with partial tears, and theoretically, it makes sense. I think that if a patient, had a certain type of tear and it was a stable tear, and you're creating bleeding and you're giving them blood flow in the knee by that PRP injection, I could see how a small stable tear would heal. But the truth is we have no evidence of it. So it's just a guess at best.
Yeah. But would you agree though too? It's not harmful if it's being done. It's not going to put anyone
That's the
at
thing.
harm.
It's not harmful.
Yeah.
So what I tell patients who are really, really interested in PRP is it's generally not harmful. They're very, very, very minimal risks. And if you're curious and if you think that, and the physician thinks that you are a good candidate, and even though the research isn't showing it, for certain things like small partial tears, or small stable partial meniscus tear and things like that, and you want to try it, that's fine. It just costs money. It's out of your pocket. So if you have the money and can afford it and have that luxury, you can give it a try. But just know that it's not guaranteed.
Got it. And then what about your thoughts on stem cell? So we went over PRP, saying it's for mild to moderate OA, as well as lateral epicondylitis. The research shows that it's pretty beneficial. What about for stem cell injections?
So similar, there's just not really much good data at this point saying that it's successful. So again, there are patients who have had it, and anecdotally they'll say, I had a stem cell in my ankle, I have some mild OA, and it helped me a great deal. And that's great, but I can't speak for it in terms of a certain injury, because the truth is there isn't good data yet. But in the next few years, we're going to have more and more data on that.
Got it. This is a question from Kira Marcus. For some PTs, I've seen a lot of mobilizations with movement, specifically for IR, ER, and for taping in IR for management of residual pain with meniscus injuries. Not a long-term solution. Thoughts? I guess I can take this one. I do those too. I'm a big fan of movement as medicine. Yes, we know the screw home mechanism. Yes, we know which direction the tibia should move. Am I able to really obsess if I'm getting that 5 degrees, 10 degrees of IR, ER? I'm going to say no. I don't think my hands can do that. But am I going to still move it that direction because I'm moving it the other direction, AP2? Yes. Coming to rehab approach, we learn the osteokinematics, arthrokinematics, and that we're supposed to do certain direction glides to have movement happen at that joint. I do all of them. Especially if one of them seems to be working, I keep pushing. So that's my thought, at least on the arthrokinematics from a rehab perspective. Okay, so that's a lot of the live questions. Again, if you guys have live questions, keep going. We have a lot of questions that we posted on IG story. I'll try not to repeat any of these subjects or any of the kind of topics that we already talked about. This first one's from Colin Mark. Are landing mechanics or jumping mechanics more important in preventing meniscal tears? For me, it's going to be more landing mechanics. You're going to have a lot more force going through the knee when you're landing than you are jumping. Yes, you're still going to get those same ground reaction forces when you're coming up, but you're going to get more on the way down. And not just for the meniscus, but then for a lot of other structures in the knee. It's in that deceleration phase. It's in that eccentric phase that we get a lot of our soft tissue injuries and a lot of other ligamentous injuries. So that's what I'm more focused on. But they both need to look good. You can't just focus on one and not the other. This is a question from Josh McDonald, and this is going to be very subjective, but how long should I take for a meniscus to settle down?
Well, so generally what I tell patients is I try to get them to do a 3 to 6 month period. If they have, again, no mechanical obstruction, no locking or catching, due to 3 to 6 month period of conservative management, meaning the anti-inflammatories, therapy, and the injections. If after 6 months they've tried all the things, we've done a full course of anti-inflammatories, they've been icing, they've done 3 to 6 months of therapy, and then they've had an injection, and and the pain's back, then I'll go ahead and say, okay, well, maybe we should scope that knee and do partial meniscectomy or repair on that meniscus.
Okay. And this next question by Reed Duran says, is it normal to continue getting pain 12 months post meniscus injury and rehab? And I think it just goes into what you said. If you've been doing everything that you should have been doing, you're doing aggressive PT, you're working with the surgeon, you're getting your quad strong, getting your knee strong, and you're still getting discomfort, maybe it's time to, maybe it is time to get another scope or something else. But you just have to know that you've put in all the effort first. You can't just say, I got the repair and it's been 12 months and I haven't done anything. And you can't have that. You can't have not done anything on your rehab. Sorry, my dogs are going crazy right now. True, quiet. Oh man, I got 2 dogs now. I love them to death. They're a little psycho when people walk up the staircase. Yeah. Truman. Okay. This question is from Sabrina. Why do some people feel instability when they have a meniscus tear?
I'm sorry, Mike. I didn't hear you very well.
Sorry. Why do some people feel instability when they have a meniscus tear?
So that goes back to my point. Generally, the actual rotational instability comes from the ACL, not a meniscus. So if they're having true instability, That's rare. I would actually, get it, have the knee examined to make sure we have an MRI. But if it's the most common type of instability is A to P instability or front to back instability, and it's because of the quad weakness and the knee's giving out because it's not strong enough so that the knee kind of drops for a second.
Awesome. This is a question from Luke Marshall, 57. What is the likelihood of developing osteoarthritis after a torn meniscus?
Oh, that's a fantastic question, Luke. So, when you tear your meniscus, that meniscus is not functioning the way it used to. There's a vulnerability in that shock absorber. So now there's more it's not taking or transmitting as much of the load as it normally does. So there's more contact pressure going into the tibia and the femur. They're just not as well protected. So they definitely have. There's definitely more of a progression of arthritis. There are plenty of studies now that show that after a partial meniscus, because of all the increased load and pressure, that the progression of arthritis increases too. Now, the
Well, yeah, and I'll go piggyback off of that too. What are your thoughts on this? So we know that, in the research that if we shave off some of the meniscus, which is going to help with that load bearing, that sure the rate may be a little higher for getting OA, but that doesn't necessarily mean that you can tell people that they can't squat deep, that they can't do jumping activities. It just, this is my thoughts on it, and I'd love to hear yours. It just means that we need to be potentially more cautious with them, and we need to make sure they're even stronger than the average person who's not doing those activities, right?
Oh, 100%. I actually very rarely when I tell a runner not to run or a jumper not to jump. It's actually all about weight, right? So you have this injury, your meniscus was torn, you had a partial meniscectomy, you have 70% left instead of the full 100% of for example, your medial meniscectomy. And now you're sitting there with a vulnerability on that side of the knee. And you even have a little bit of collapse and a little bit of arthritis. So the truth is if you're 10, 20 pounds overweight, the knee's seeing loads up to 5 to 10 times that body weight. So if you're 20 pounds over, that's 100 to 200 extra pounds of weight that are now going through an area that has less protection. So the key for what I always tell patients is let's diet and exercise without impact exercises to get the weight down. Once your weight is back to your ideal body weight, go back to doing the things that you love doing and the jumping or the running activities and see if you can tolerate it then. If you can tolerate it then it was just your knee wasn't able to support that weight increase.
Yeah, and that's 5 to 10 times per step, guys. And if you're taking 10, 20,000 steps, that's a lot of total volume on that meniscus. And then you're adding things like running, jumping. It's just the volume that's high for you. So if you're able to decrease some of that volume through either shortening your runs, going on less jumps, decreasing your weight, and then again, those are more like temporary things. So you can start your activities again. You can build yourself back up. Regardless if you have a meniscal injury or not, you still need to watch your volume with any activity and get strong to do that certain volume of activity that you want to do, regardless of any injury or surgery.
Yeah, and I haven't really mentioned this enough before. I should have earlier, but when I talked about conservative treatment for a meniscus, I forgot to mention the weight management. But the bottom line is weight management in general is one of the most important things we can do for our knees. If you control your weight and you're at your ideal body weight, even if you have injuries in your knee or cartilage damage, meniscus tear, you're going to be having less pain and your activity level is going to be much higher than someone who's overweight. So it's better, that 5 to 10 factor, you can do more for yourself than oftentimes than even Mike or I could do for you if your weight is at your ideal body weight.
Yeah. And that's just population health as a whole. I mean, especially us in America, where we're eating, the lack of exercise, it's more than just your knee that you're going to be helping if you lose that weight. It's helping your cardiovascular, your mental health. There's so many things, just staying active and staying moving. And so it's such an important.
And even though I say that, I should take my own advice because as soon as Thanksgiving hits, I'm always gaining 10 to 15 pounds off of those damn cookies.
This is a question from Vincent. I've seen some meniscus prosthetics going around. Is this something we might see more of in the future?
Okay, so is he talking about meniscus transplants?
My guess is transplant. Yeah. That's
okay. So meniscus transplants can be a very good option, especially if someone had a near total meniscectomy and they're young, especially these athletes who are like 20s, 30s, teens, and they had a really bad injury, the meniscus couldn't be saved, and you want to give them the opportunity to protect that joint, protect that cartilage. Now, meniscus transplants have been shown to have up to an 80% success rate at 5 years, even maybe up to 10. Now, not everyone is a candidate. We take those, it's a complex process to make measurements, meniscus from the menisci from a cadaver, somebody's really passed away, and then try to make sure we measure it right and put it in. It's not something benign that we can do, or something that we can do to save someone who already has arthritis. We want to do this to prevent athletes or younger people from getting worsening arthritis and give them a higher quality for a longer time.
That's cool. I guess that's the question I always had. When we get these, donor organs, knees, meniscus, cartilage, whatever it is, what is that process like? I assume things have to be freezed. I'm sure there's like a chemical process. I'm sure there's certain timelines. Like, do you know, like, how does that work? Like, how does it get to you if you're using that tissue? Like, what's that process like?
Oh yeah, it depends on what the tissue specifically is, but there is a freezing process. There is a washing process with antibiotic solutions and other solutions. There is a radiation process, which is a plus or minus, because irradiating grafts, for example, like with an ACL, when you irradiate this tissue that we're using, you're actually weakening the quality of it, but you're decreasing the amount of disease in it, or like the risk of disease in it, if you got it from someone who had some type of a virus or whatnot, such as hepatitis or HIV. So it's a full process, but it's a juggling act, right? You're trying to keep that tissue as strong and as normal as possible, but also make it the least likely to be rejected or cause the patient any harm or transmitted disease.
Right. All right, just letting you guys know, we're going to wrap up in a couple minutes. I want to answer a couple other questions. This is from Solicit 10P. If my knee is feeling like it's popping out of socket, shifting, etc., and I have to shake it back in, is that a meniscus injury? It doesn't lock and the ligaments feel okay.
So I've heard that described a lot. And from my perspective, that one's always hard to understand, because popping out of socket, you think knee dislocation or sometimes patellar dislocation. But I've heard many patients describe that when they actually have a meniscus that's flipped and they're having some type of almost like a locking mechanism that's unlocking, and it's basically catching. It's locking and unlocking, right? And then we end up seeing that they have a meniscus tear. And for some reason, patients do describe it like that. So you could have a meniscus tear.
Interesting. Okay. This one is from Luke. I have a torn meniscus and waiting for a scope. Is it okay to still squat and lunge to keep the quad strength? And I'm not sure what the rest of the question is. But I would say, you have to work within listen to your body. If you're getting pain with them, I would stop. And I would, like Dr. Mehran said, I would, decrease the amount of knee flexion that you're going to avoid those deeper angles, especially if it's like horn, stick to more open chain exercises. And I'm sure you guys have been following our IG story. We teach blood flow restriction training, and that's really where it comes in. When we're not able to put these loads through people's joints, we can incredibly decrease the load, working at 10, 15, 20% of our RM. We put a cuff on our limb, and you're able to get the same strength and hypertrophy gains as you would if you're lifting like a heavy, heavy squat. And that's how we can really decrease the amount of stress that goes on the joint or the meniscus or whatever injured tissues there are. So listen to your body.
Absolutely.
Yeah. Going through some of these, we talked about that. Squat. So again, for those of you, if you guys joined, we had another question. At what time post meniscus repair surgery can you perform a deep squat body weight? You mentioned 3 to 4 months, more on the 4 month side, nothing past 60 degrees in knee flexion. Is that correct?
Mm-hmm.
Perfect. We talked about open chain and closed chain. Just to recap, open chain is totally fine as long as they don't have patellofemoral issues. I know for me in the clinic, I'm a big fan of open chain because we can actually isolate the quad in open chain. When we do closed chain exercises, yes, I can tell by the joint angles and their biomechanics and where their weight is what I would like to bias, the hamstring, the quad. I still don't know what the MDIC is. I still don't know what they're actually ramping up. In closed chain, it's very easy to cheat and people offload painful structures. So open chain, it's hard to cheat if it's isolated. How do I know if microtears? I think that is most of the questions that we have here. Yeah, I guess let's wrap it up here. So, guys, we did this for about an hour. Thank you for sticking with us. This was awesome. I learned a ton. I hope you guys learned a ton too. Thank you, Dr. Mehran, for hopping on. This was really, really fun.
Absolutely. It was a pleasure for me. Yeah. Thanks to whoever told me how to sign in. Otherwise, I would have been lost forever.
I could have was too. I was looking for the button. I was like, I swear there's like an invite button because I know it's popped up, but I had no idea how to get you on. Yeah, let us know, guys, if you guys like this. We've been we've been toying around with the idea of doing a podcast, the two of us.
Mhm.
And if you guys are interested in that, talking about injuries, talking about return to play, when it comes to sports injuries, if that's something you guys are interested in, let us know in the comments. Let us know, DM us. And yeah, we'll hope to do this again. We'll have this available on our IGTV. We'll have it available on YouTube. Dr. Mehran is going to be taking, I don't know if you already took them, some surgical clips of doing a meniscectomy or repair.
Yeah.
And we're going to put together a really cool video kind of going over the differences between the two and what they look like, under the scope and in the microscope. And then we'll be talking about the rehab side, and he'll be talking about the surgical side. A lot of cool content we're going to make out of this. So again, appreciate you coming on. Hope you have a good day. Any last closing points? Let's do that. Any last closing points that you want to hit on?
No, I just thanks for having me, Mike. This was a fun treat for me, my first time doing it. I think the key point for all of your injuries and in general for like your health is, try conservative management first. Certain things that truly do need surgery, certain traumatic injuries, obviously some car accidents, really bad broken bones, you do have to be fixed so you can have your anatomy back. But in general, if you can try a conservative approach, you should always try that first before going to surgery. Surgery should be your last resort, and finally control anything you can control. Because if you can control, your weight, for example, if you can manage it, make it a little bit less and it causes you less pain, you can control, your strength and working with a therapist and build up your strength. Take care of those things first before you jump to the quick fix, because the quick fix isn't always the answer.
Yeah, you're going to be putting in a lot more work after the fact anyways.
Yeah.
Note too, for those of you guys that may be going through rehab for a meniscus injury or something like that, know that all the work that you put in before isn't to no avail. Majority of people do respond really, really well and never have to go down the route of surgery. But even if you do, all that work you're putting in before, getting all your range back, working on all the soft tissues, getting extremely, extremely strong is going to set you up for success afterwards. And people that go into surgery stronger are going to have much better outcomes. That's actually the article we just did this week. It was actually on knee surgeries and prehab exercises. So know that you're not wasting your time. Don't ever think that don't want anyone to ever think they're wasting their time getting their knee stronger. So
yeah, absolutely. Couldn't agree more.
All right, guys. Thank you for tuning in. Again, Dr. Mehran, if you guys want to follow him on Instagram, I pinned it at the bottom. It's at DrNimaMehran. Follow him on Instagram. He posts a lot of awesome stuff.
Thanks, Mike. I really appreciate that.
All right. See you guys. That was fun.
That was good. I thought it went well.
Yeah, so we had I don't know, are you able to see the stats while we're on too?
I definitely can't see anything.
Okay.
I was worried my phone was going to die during the whole process.
I started holding it.